Thank you. I want to thank Marwan for putting together, again, a fantastic symposium. I was asked yesterday, what is an electrophysiologist doing here, that it was nice for me to be seen. So besides teaching the transeptal skills, I'm here to present the ablative arrhythmic phase of cardiogenic shock. None of these disclosures are relevant to my presentation today. We've known for a very long time that arrhythmia begets worsening heart failure and that worsening heart failure begets arrhythmia. In fact, this was described even before the advent of EKG. And so in terms of the faces that you would see, it's not uncommon to see somebody with acute exacerbation of chronic congestive heart failure leading on to cardiogenic shock with a VT storm on this little strip of paper alone, defibrillator interrogation showing about 7 episodes of VT treated failed with multiple bursts of anti-tachycardia pacing and shocks. Very often these patients are already on very high dose amiodarone and a variety of other antiarrhythmic therapies which have all been unsuccessful to various degrees. Very often the numbers of VT are sometimes in the thousands in this patient, in excess of 1,000 episodes of VT that have been treated. This is what I would call paroxysmal sinus rhythm as opposed to paroxysmal VT. It's not uncommon to see something like this. And when you have something like this, you actually have the luxury of getting a very nice 12-lead EKG of the patient in ventricular tachycardia, which sort of facilitates where you want to concentrate on in the heart in this patient with a large inferolateral scar in the left ventricle. Sometimes the disease is not in the left ventricle. Here is a patient who presented with cardiogenic shock in a setting of non-ischemic myopathy, and this is a classic presentation of arrhythmogenic right ventricular dysplasia. You have a left bundle form of VT with very positive R waves in lead 1 and AVL. We had to perform mapping of the both endocardium and epicardium of the right ventricle in this patient for ablative therapies. Sometimes it's not even in the ventricle. This is a patient with rapid atrial flutter, sustained atrial flutter, deteriorating periodically into 1-to-1 atrial flutter, which led to worsening heart failure in this patient and cardiogenic shock. So in looking at this, is there any data? And again, the paucity of data is quite incredible. This is one of the largest accumulations of data from the VT collaborative group. And out of these 2,061 patients, you can see about half of the patients are ischemic, which is not surprising. And a third of patients are what they call advanced CHF, and VT storm presentation in about a third of patients. There is no mention of cardiogenic shock in this patient because it's not been studied. So even in this population of quote-unquote advancing CHF, the mortality is pretty abysmal, and more than half the patients have unmappable arrhythmia. But what do I mean by unmappable arrhythmia? So before we come to that, the Penn group attempted to try to predict, to put together a score of some predictors of hemodynamic decompensation during VT ablation. And so the bold letter stands for a score that they came up with, and it's called a PAIN-SD score, standing for pulmonary disease, older age, use of anesthesia, ischemic myopathy, worsening heart failure, and so forth. And while this is a good score to discuss for an outpatient with some bursts of paroxysmal VT in the clinic, I have not found this score to be useful. As you can see from the score, almost 100% of my patients have, in cardiogenic shock, when I'm called by the heart failure team to see them in the ICU, have scores way above 17. And so I have not found this score to be very useful to me in evaluating hospitalized patients with worsening heart failure deteriorating to the point of shock. So, and what do I mean by unmappable arrhythmias? Here's a 10-second strip of multiple monomorphic VT. On this little slide, you have 3 different forms of VT, but the most important line is down in the bottom, the arterial pressure hovering around 0. So this is not much as the Josephson chapter on electrophysiology is well over 500 pages of different outer loops and inner loops and isthmuses. This is not a patient in whom you can study any of that because you have a blood pressure close to 0. And the patient has to be rapidly defibrillated in order to, to restore flow. So what do we know about those groups of patients? In a small study of patients who underwent VT ablation, about 40% of the patients required some kind of supportive measure, mechanical cardiac support. And when we undertake VT ablation, this is very much in concert with our heart failure colleagues, and we're very blessed to be able to do that. The problem is if you don't identify the patients who need support up front. And in this group of patients, the 13% of patients, which I think is actually a little bit small, who suffered acute hemodynamic collapse, the mortality is extremely high in that group, because you're trying to. Now, here is a patient with scar homogenization of a very large LAD infarct. And when you're dealing with something like this, you need the patient to come out of the lab alive, not just no VT at the end. So perfusion, establishing a plan for perfusion both during and afterwards is very important. So some rules of thumb that we employ are, here's a patient in sinus rhythm with a reasonable arterial waveform shown below. And simply pacing him at 100 beats a minute, we're not inducing VT or anything, we're just ventricular pacing at 100 beats a minute, you can see the arterial waveform suddenly dramatically drop when compared to here to here. That's not a patient who's going to do very well with any attempt of VT ablation in the traditional sense. So in some of these patients, when we see an increase in left atrial pressure of more than 25 millimeters, or a drop in MAP with RV pacing, we either look at mechanical support options. We're able to now map some of these patients using either a paced configuration of VT and try to map it using advances in our traditional mapping. We have a mapping system where we look at late potentials, and we have learned to map isochronal, what we call late potential mapping, called isochronal late activation mapping. And I'll leave you with just a video of this where we're able to target during sinus rhythm without inducing VT in order to avoid hemodynamic decompensation, identify channels within, and use that as a surrogate for VT so as to also minimize the amount of time we do any pacing maneuvers, as well as try to limit the amount of myocardium that is ablated. And given that my time is up, I will leave you with the plea that while we have very sophisticated mapping and ablative tools, we want to try to identify patients who are at risk. So in the SCAI classification of cardiogenic shock, we want to try to get to these patients in stage A or B. And if you're already calling us in C, and most certainly a D, the outcome of VT ablation is going to be poor. So if you're, on the other hand, if we're able to identify patients in stages of A and B, we're able to do a much better job. And many times, in my opinion, at least the arrhythmic component that contributes to their hemodynamic deterioration, we're able to both avoid and reverse. And with that, I'll stop, and thank you for the opportunity.
How often do you find that you have to do epicardial ablation, and is that more or less complicated in this patient subset?
So traditional teaching is that non-ischemic myopathy, the majority of substrate is epicardial, so much so in traditional, 70% is a number that has been coded, and ischemic substrates, traditionally the teaching has been that the majority of the circuit is endocardial. Increasingly, there is a new recognition that a significant component of the substrate is also epicardial. The problem with some of these patients, especially if they're on other kinds of support, is that they're also anticoagulated. Some of these patients have also had previous valve surgery or bypass, and it is not easy to get to the epicardium. Certainly in the non-ischemic substrate, we routinely plan to go, we do a dry epicardial stick and map the epicardium. And when possible, we would like to do that in the ischemic patients as well, but it is not possible to do that in all patients.
Great. Of course, we are very blessed to have guys, very talented guys like him in our heart failure group that we call them in extreme stage E shock. They still do a very good job VT ablation, because that's the time we remember him. God and electrophysiologists to remember only in stage E. A, B, C, we don't. But just to ask a question, like you said, your first slide, heart failure begets VT, VT begets heart failure. So when you unload a ventricle, say in a patient where you are scared that this VT would be hemodynamically unstable to induce, and then you unload him with tandem impeller, whatever else that you use, and suddenly the hemodynamics of the heart is better. Do you find it more difficult to induce that heart, or this new technology which you showed is good enough?
This is a very good point. In fact, we would prefer to do this in a very compensated heart. So when we find, for example, when we simply pace the right ventricle at 100 beats a minute, and the MAP is less than 50, and the left atrial pressure, or surrogate or wedge, increases by more than 25%, we already know we're going to have a decompensating patient. So we will typically ask them to either consider some form of mechanical support, which would dramatically reduce the amount of VT. The best part of the high-density mapping systems that we have is that we are able to target zones of slow conduction in sinus rhythm without having to induce VT. Now, we may need to come back more than one time, because our aim is to not go eliminate every form of VT that is possible. But if we can reduce the burden of VT from somebody who's in 80% of the time in VT to 5 to 10% of the time, we have already de-escalated the patient's severity, and we can bring back the patient for a second time. It's the difference between a palliative ablation for VT versus trying to go for a therapeutic ablation. So yes, the burden of VT drops dramatically because the LVEDP is dropped, and to the extent that that is contributing, it will. And then we can come back in a much more stable situation and go for a more extensive ablation, even if it is a one-time procedure.
So I had a quick question. So this is kind of an interesting talk, because in a way, if we were to kind of extrapolate this to general cardiology, this is almost our prevention talk, right? Prevention of shock, because hopefully most VT ablations are not stage E that are being sent to you, and if so, you can complain to them, because that seems like a mean position to put you in.
Well, it's not so much the colleagues that call us, it's sometimes the patient is sent to them in stage E, and they don't have a choice of calling us at that time.
My question is, I think sometimes in terms of kind of preventing shock from happening, right? You saw the numbers you presented, that there is a substantial portion that decompensate during the VT ablation. Do you guys have processes in place where it's not the heart failure team that's sending you a patient, but you're getting a referral for a VT ablation? Is there some metric that you hit that you need to have heart failure involved a priori to have that discussion, one, to help guide decision about temporary MCS, but also if you get into trouble and we end up, the last talk is about exit strategies, sometimes some of our EP docs like us to do a full VT ablation, VAD evaluation before the VT ablation to see exit
100%, except in the structurally normal heart, 100% of our VT ablations we do in collaboration with heart failure.
Okay.
So they're actually admitted to their service. We don't even admit them to our service. We admit anybody sent in for VT ablation in a structurally abnormal heart to the heart failure team, and so all those patients are discussed. Anything that is structurally normal who comes in with the outpatient, we would do it.
Ours is a very unique this thing, because our heart failure, advanced heart failure and VT is in the same division. It's a very odd thing, but for this reason only, that we cross-pollinate each other all the time, because as you know.
And we truly see this. We've seen worsening arrhythmia land up in their service, and worsening heart failure patients land up in our service. So we're a common service for that reason.
To follow up on the support issue, how much does it complicate your life in places that are predominantly Impella programs? How much does it complicate your life to have an Impella banging around in that ventricle?
I know several of my colleagues in the country are fans of Impella. I am not a fan of Impella for VT ablation. I'm not going to argue about its merits for purposes of improvement of outputs and perfusion that have all been discussed. It complicates our life a lot in terms of the ability to map, and I just, there's so much real estate in the ventricle. There's already so much real estate in the groin in terms of access issues, and then there is so much real estate in the ventricle that I think you land up spending more time trying to avoid the cannula and all the issues that go with it. If truly we believe that the patient, it cannot be done without support, then we will say we'll wait until, some other form of support, either tandem or, go for a VA ECMO or some other form of support before we do it. It just is I've not found mapping ablation in Impella to be any kind of satisfying procedure.
We developed a hybrid strategy with Ramesh and his team, because we worked so closely for so long, is that when they go for VT ablation, in patients who are very unstable, of course, we put whatever device we put. But for most of them these days, they do a transeptal, keep the left atrial cannula there, and induce the VT. If while doing the VT, they see the LA pressures are dramatically going up by induction, they'll call us. They've already done the transeptal. Impella tandem takes another 5 minutes to put in.
We call it a tandem standby approach.
It's a standby approach.
So we leave the transeptal in place. Either we use that to go transeptal or we leave it there. And very often we found we will do surrogates. If we're doing a long ablation, like that extensive scar modification of that LAD scar, we'll measure PaO2 periodically and we'll see LA pressures rising. If we wait for hypotension or EMD, that's way too late. You want to try to identify some of these patients well before. And we'll start seeing creeping up LA pressures well before some of these other surrogates have been reached.
Can you comment on salvage VT ablation on AMI shock? You're on temporary support. It's not pump failure, but it's just refractory VT on MEO and LIDO combination. Yeah. As a salvage to LV recovery, is there any role of VT ablation?
So this is obviously, you know, the traditional teaching is all VT in the setting of acute MI is all ischemic, and that is true. If you're able to revascularize it, number 1, 2, and 3, that would be absolutely the number 1, 2, and 3 options. But very often we'll see VT, we'll see an acute MI or some kind of insult on a chronic ischemic substrate or de novo that either, not just polymorphic VT from acute ischemia, but one that either injures the Purkinje potential near the fascicle or that completes the scar circuit, so you start getting monomorphic VT that is repetitive. And I believe those are two different beasts. It's not the same as an acute electrical storm from an acute MI, which you truly want to decompress the ventricle and you want to try to revascularize to the extent. Some of these other forms of VT are not related to, you've either completed a scar circuit or and we've had to take them, previously we were like, you know, very hesitant to take some of these patients to the lab for obvious reasons, but we've now been able to try to target our ablation to the sole arrhythmia, not go after all the ischemic substrate. And we've had reasonable result in carefully selected patients in concert with our heart failure team where there is either a Purkinje potential that is firing that induces multiple bursts of VF, or go after a limited ablation of a VT in the penumbra of an infarction, which was responsible for completing the circuit, with the intent that we may need to come back another day to do other things, but at least we can salvage the situation currently where, so in carefully selected patients, absolutely there is a role for some of these patients.
Oh, that was great. Thank you very much.
Thank you very much.